My name's Linda Smith and this is Lisa Turnbull. We work for NHS Lothian. We work in the drug liaison service. So Edinburgh's smaller, obviously, than Glasgow. It's the second biggest city in Scotland. So we've got 560,000 in Edinburgh population. So the drug liaison service, last year we saw 508 patients. This year so far we've seen 470. And compared to my alcohol liaison colleagues, they saw 1,049 last year, and this year so far they've seen 871. So our services are separate, whereas in some areas of Scotland, the substance use teams within the hospital are together, they work together. So who we are. So we started in March 2018 following the MPS crisis that we had in Edinburgh. That's when the drug liaison service started. We're a nurse-led community-based resource. So we are part of the harm reduction team. We're not employed by the hospital. We're one of the community teams and we do in-reach into the hospitals. Very small team, 2 full-time equivalent nurses and 2 part-time equivalent assertive outreach workers. So we're a key link between the acute and the community service. See patients who are dependent, have erratic or hazardous drug use. So what we ultimately want to do is to improve the patient group's hospital experience. They may have had unsatisfactory previous experiences in hospital, and we focus on improving patient outcomes to hopefully allow them to remain in hospital to get the treatment they deserve. We give reassurance to both the patients and the staff. Hospital staff have a limited understanding of the needs of our patient group, people who use drugs. So what we try and do is relieve the distress and symptoms of withdrawals, to give adequate withdrawal treatment, but also treatment for acute pain. If somebody's not on a prescription, we can start them on a prescription when they get to hospital. It can be an opportunistic time when somebody presents at hospital, so we need to use that time. And medical conditions that our patients experience are often masked, neglected or hidden until they come into hospital. Nobody wants to be in hospital. I don't really want to be in hospital being a nurse, but that's what I get paid for. So if I can make somebody's experience slightly more better, then I've done a good job. So what's changed? Oh, it does work. So like what Peter was saying earlier, we've seen a humongous rise in cocaine use. Lots of cocaine injecting as well. So substance use has evolved. We used to see a lot more kind of near-fatal overdoses, but now we see a lot more skin and soft tissue infections, but also severe injecting-related infections, which we more commonly call SIRIs. So the way people use substances has changed. Obviously, a lot more cocaine injecting. In Lothian, we've kind of noticed it within the last couple of years, really. It's just gone up and up. So because of this, we're seeing frequent hospital presentations, a significant increase in the SIRIs, severe injected-related infections. So unfortunately, patients are presenting with more complex, deeper infections. So it's not just a groin abscess or cellulitis. You know, it could be an infection that has gone to their back. So they might have discitis, they may have endocarditis, an infection on the heart. So it's affecting different, more larger organs of the body, which means that people will have to have potentially surgery, longer lengths of stay in hospital, because the IV antibiotic treatment is extended and for longer periods. which is costly, but it's also poorly tolerated within our patient group too. So, the aims of our service, if somebody's not already on medication-assisted treatment, we can initiate that when they're in hospital. Provide harm reduction advice, provides expert infection advice. So on a Monday, we have like a team. We have an infectious diseases consultant that spends the day with us. We have the drug liaison nurses, and we also have an assertive outreach worker. And we go and see patients who have the severe injected-related infections, and try and rationalise their antibiotics, make sure they're on the right antibiotics in the first place, but also kind of see where the patient's at. If they are willing to stay in hospital, that's great if they are. So what can we do? Is there anything we can assist with whilst you're in hospital? If somebody's homeless or at risk of homelessness, we can get the Cyrenians Homeless In-Reach team to see them. We've got LEAP peer support workers that come in as well. So if anybody is thinking about recovery, we can get the LEAP peer supporters to see them. We've got a Cocaine Anonymous group on a Friday and a Saturday evening. If somebody isn't able to remain in hospital, then we can try and facilitate a patient-directed discharge instead of a discharge against medical advice, because the patient is they're deciding to leave hospital. So if that's what you want to do, then how can we make it as safe as possible for you? So we can organise effective treatment and follow up for this. For example, if somebody still requires ongoing antibiotics, we can ensure that they have an antibiotic that lasts for a couple of weeks, just a one-off dose of antibiotic, and then they would go back to the outpatient's antibiotic treatment service. 2 weeks later, we can provide support for somebody to get there. They get their bloods checked, potentially get the additional antibiotic intravenously, or it might be oral antibiotics. It may be that somebody's struggling to mobilise, their mobility is compromised, but they can't make it to their GP to pick up their new prescription. The following day, we can support them to take the person to the GP to pick up their prescription, and then to potentially get them to register with a GP closer to where they are staying. Or a lady was unsure that she wanted to remain on treatment because her partner wasn't on treatment. He wasn't registered with the GP, so couldn't access treatment. So we got the registration forms for the local GP. He completed them, and then we kind of took them to the local GP service. So it's more of a holistic approach, just seeing where the patient's at, taking it where they're at, and we're advocating for the patients as well. So that's just some of the people that are involved within the patient care. Obviously, the patient's at the centre of this because it's person-centred care. But it's collaborative working with clinicians, bloodborne virus nurses. If somebody has a Hep C diagnosis, we can hopefully get them started on treatment when they're in hospital. Infectious diseases spends time with us on a Monday, but then she would also follow up the patients in the outpatient's antibiotic treatment centre, either following that week or the next week, so she knows who the patient is. Third sector could be Cyrenians Homeless In-Reach team, potentially the navigators, could be CGL, could be the Simon community, pain team, and housing as well. So that's just a little characteristics, if you like. So you can see there that the cocaine use, sort of 80% of patients reported cocaine use. So these are last year's statistics. So you can see the skin and soft tissue infections, the spinal infections. I mean, these are ones that patients would stay in hospital for approximately 6 weeks, and unfortunately they can be recurrent infections as well. Endocarditis, I mean, this year we've seen about 5 different patients that have had endocarditis, and they're all under 30 as well. And then this is sort of like historic and from our interventions. So you can see there that the readmission rate's gone down. Patient-directed discharges has decreased. But also the infectious diseases follow-up has increased. And then, you know, if somebody attends just one time, it's increased. At least they're getting their bloods checked, and just to ensure that the markers are going down. That's the most important thing. So I'm going to hand you over to Lisa now.
Hiya. I'm going to present 2 case studies, patients that are with our service, just to showcase their journey with us and how the services supported them. So first we have William. He's a 46-year-old man. He was admitted to hospital last October with staph aureus bacteremia infection. So he had to stay in hospital for about 4 weeks for treatment. So the drug liaison nurse is Linda. She went to see him, checking he's on a script, his pain management, and then linked him in with myself. So then I would go and see him weekly, try and build a rapport, and just planning for his discharge and what support he would need in the community. He has a long history of substance use, injecting, substance use starting in childhood, significant trauma. So he was discharged from hospital to homeless accommodation. He was in touch with Cyrenian's in-reach team, and he could have went to step-down care at Milestone, but he felt that he didn't want that at that time, so he was placed in a B&B. Unfortunately, the conditions of the B&B were awful for him. He had just spent 4 weeks in hospital getting IV antibiotics. He was then having to go to OPAT weekly to continue that treatment. So staying in a B&B where the conditions weren't great for him, he felt it would be better if he was on the streets. So he did leave that accommodation, slept on the streets for a couple of nights, sofa surfed with some friends, and then got in touch with myself less than a week after being discharged, saying that he was really struggling. He had used again and can re-support him. So I contacted Cyrenians, linked him back in with them, and the very next day he was in the step-down care at Milestone House. He did struggle initially to be in that environment, in the step-down care. On one occasion when I went to see him, I found him in the bathroom overdosed, but I was able to offer support in the immediate aftermath of that, and also to advocate for him with the staff at the accommodation, because they were thinking that he would maybe need to be discharged from that accommodation. However, liaising with them, they gave him the chance, and it was very successful. He didn't use again whilst he was there. He was placed in accommodation that it's his own flat, but it's got staff there Monday to Friday 9 till 5, and he's been thriving in that accommodation. And he's been working closely with Cyrenian's in-reach team on their interview panel. So they had recruited some support workers, and he was on that panel helping them to recruit the support workers. So he's done really well. So that's some of the outcomes. He's in stable accommodation now. is on a methadone prescription. He was on a prescription when he came into hospital, and he has maintained that in the community. No further hospital admissions or NFOs, and is not currently injecting or using any drugs and working with Cyrenians. So the next case I'm going to present is Teresa. She's a 33-year-old woman. She was admitted to hospital following being found in a stairwell, collapsed, following a near-fatal overdose. She has a background of significant trauma, has been using heroin for a very long time. Currently, she's using heroin and cocaine. She is in a relationship with someone who deals drugs and felt very trapped when we first started to see her, because she didn't have, our benefits were sanctioned, she didn't have any money, she was dependent on heroin, and this person was able to supply her the drugs. So she did feel very trapped. So following discharge, we tried to engage Teresa. We went to her flat every single week for about 3 months. She didn't answer the door, she didn't engage, we kept on putting notes through the door. The point in going every week was to show her that we aren't going to give up. Like, if you're not ready for this just now, we will still keep on coming, and when you're ready to answer that door, we will be there. And that's exactly what happened. We went one day 3 months later, and she asked for the help. She said she was really struggling. She felt really trapped. She wasn't on a prescription. And then Linda started our outreach prescribing, so she was able to take her on in the community. So Teresa didn't need to come to a service to get onto a prescription. Linda would go to her home. She started her on the prescription from her home. She would give her prescription to take to the pharmacy, and Teresa had to go to the pharmacy to get her prescription. So that barrier of coming to the service, which was quite a bit away from her house, that was taken away, and she was able to go to the pharmacy. So since engaging with the assertive outreach and the assertive outreach prescribing team, Teresa has not had any more near-fatal overdoses. She has only had 1 hospital admission, and she's remained on a prescription for the last 1.5 years. She was linked in with Simon Community Street Work homeless organisation, and they were able to support her to get her benefits reinstated, so she now has some financial control. Her life is still quite chaotic. She is still with the person who is selling drugs, but her goal is to work with us, and eventually when she finds the strength and it's the right time for her to get out of that relationship, we'll be there to support her to do that. So it's just about being there for her and working with her at her time, and with all the patients. Do you know, William, he's not using and he's free from drugs. It's a very different story to Teresa, but Teresa, for her, the main thing is staying on a prescription and engaging with services. So yeah, she's been stable on the prescription, as I said, no further NFOs, 1 hospital admission, and access to her own benefits, and future planning to leave the relationship and stabilise. So William said, you gave me a life back, and I'll never forget that, which was really nice. Teresa, she said that even on days where she does not want to face the world, she does not want to go out, we will be there and we will come to her, and she doesn't have to go out and she doesn't have to face the world.
It's just some acknowledgements from the rest of the team. Kirsten Ellis, she works in West Lothian, but also we couldn't do it without the assertive outreach, without our Cyrenians and the street work, Simon Community.
So we do outreach with Simon Community, and the thinking behind that is we used to go in with 2 our substance use service and another substance use service, but we were finding people had housing issues, benefit issues. So we thought it would maybe be more beneficial to link up with a homelessness service that deal with homelessness benefits. So yeah, we go out with them once a week. Okay. Thank you very much.